Well, good afternoon, everybody. Welcome to this webinar showing how NICE is transforming. It's fantastic to see so many of you joining us here today and to hear more about NICE and what it's planning. My name is Jennifer Dixon and I'm the Chief Executive of the Health Foundation, and I'm really delighted to be your chair for this afternoon. So we have an hour and we have two speakers, Dr. Sam Roberts, who is NICE's Chief Executive, and Professor Jonathan Benga, who is NICE's Chief Medical Officer. And what I'm going to do in a minute is just turn to them, and they're going to give presentations for about 20 minutes apiece. And then what we'll do, we'll have a Q&A discussion afterwards. So please do ask your questions and make comments, perhaps when the speakers are speaking, and just submit them via the tab on your screen. Don't hold back. We'll probably not have a chance to answer all of your questions, depending how many of you ask them. But rest assured that NICE colleagues will go through everything you submit, so please don't hold back. And in addition to the Q&A, I know that Jonathan in his presentation will be asking you some questions in the polling that he's going to be doing, so you can engage that too. So NICE is very keen to have a conversation with you and engage with all of its stakeholders. The Get Involved tab on your screen will link you up to NICE's social media channels, and a link also to sign up to its newsletter. So please do that. And this will keep you up to date with news and future engagement events. So hopefully that's of interest. And the final tab to mention is the link through to NICE's newly launched webpage, which describes its transformation that you're going to hear about this afternoon. So something that you can refer back to having heard today's presentations. And we're going to wrap up today by 5 o'clock as promised. And today is going to be recorded. So if you have to nip off and get some coffee or tea, don't worry, you won't miss everything. It's recorded so you can listen to it afterwards. So before I just turn to our speakers, I'll just say a few opening remarks. So just to say, I think as you all know, NICE has been around for a long time, since 1999. And as you know, its evidence-based guidance spans quite a lot, not just new treatments, but also existing treatments. And it also covers not just drug treatments or clinical procedures, but also health technologies, clinical practice guidelines and care for people with specific diseases and conditions. It provides guidance on health promotion and guidance for social care services and users. And in doing all this, the tricky thing is, of course, is that NICE is legally required to have regard to a number of factors, one of which, of course, is the balance of costs and benefits. But also the extent of population need for the new interventions and treatments it looks at. And also NICE also has an objective to promote innovation as well. So that's quite some balancing act, but NICE has performed extremely well, I think you'll agree, over the last near quarter of a century. And there probably can be no bigger testimony that it hasn't been abolished or merged indeed, quite some feat over that period. And NICE also has a very excellent international reputation as well as a national one. But as we know, I think, and as NICE's strategy sets out, there are some very fruity, huge challenges ahead, and that everyone, as well as NICE, has got to respond to. And I think there are probably 5 big ones, and I'm sure they'll come out in the presentations today. The first one, I think, is first and foremost is economic growth, which in the UK is unfortunately not as strong as we would like, and not enough to power health system growth in the way that we've become accustomed. So this means in the future, unless this changes, it means a bigger focus on implementing labour-saving technologies. It means focusing on productivity, prevention, and on the care of frail older people. I think that's sort of a given. I think the second big challenge is demography. And as we know, there are increasing numbers of older people, which is good, particularly people aged over 85. And certainly that will be a bulge over the next 30 years, as well as a smaller share of working people, global health worker shortage. I think the third area is, of course, demand. As we all get older, we'll have multiple chronic conditions, most likely. But there are also some mental health trends in the young that we need to look at and be worried about. There's also obesity, which is baking in ill health that we'll have to take account of, and of course, inequalities in health. And I think there'll be a lot more focus in future on worker health, given the worker shortage, and also a bulge in the end-of-life care in the next 30 years. So I think those factors will influence demand. And increasingly, there may be demand in future, not just for treatments for ill health, but also growing demand to help them mitigate the risks for future ill health, fueled in part by increasing risk predictive tools that we're going to be seeing with polygenic risk scores, amongst many other things. So those are some of them. And then on the supply side, of course, there's a global shortage of health workers, despite the NHS workforce plan. A lot of technologies will be hitting us, in particular artificial intelligence coming thick and fast. How do we assess them quickly beyond our current ability? How do we shift into gear that way? And how do we assess the shift into integrated care and more community services? A lot more will be and have to be delivered in the community. So how do we work with integrated care systems and their like? And not forgetting, amongst all of those challenges, of course, the ongoing net zero challenge, which is also coming our way. So in April of 2021, NICE produced a new strategy that recognised these huge challenges and how it would develop its work to respond to them. And of these, I think among the biggest probably is the waves of new technologies that are going to be hitting us, as I've said, where the need really will be to develop agile and rapid iterative forms of evaluation and guidelines to match. So how will we do this? I think these living guidelines, as they've been called, is really a case in point for us all to work towards. So we're going to hear a lot about this, and it's the crucial work that NICE is doing in this area now from Sam and Jonathan, and both of whom are extremely experienced. And they also have fresh eyes, having both joined NICE in the last 18 months, and really can look at the NICE's fabulous work afresh as we meet these challenges. So just a reminder, as they begin to speak, please do ask the questions, and we'll get as many as we can in the Q&A after the speakers. So with that, I think what I'll do is just hand over to Sam, Dr. Sam Roberts, who, as you know, is the Chief Executive of NICE, who's going to give her presentation, and then she'll be followed by Jonathan. Thank you.
Brilliant. Thanks so much, Jennifer. So, hi, I'm delighted to be with you today, Sam Roberts, Chief Exec of NICE, and thank you so much for so many people joining us at 4 o'clock on a Monday afternoon. I think, as Jennifer said, undoubtedly we live in tricky times. All the list of things that we've just talked about, rising demand, health inequality, economic productivity, etc. And on the industry side, we're also seeing a period of declining R&D productivity and real affordability pressure. So when we speak to our colleagues in similar roles around the world, they're saying that their health systems are struggling to afford the waves of innovation that are coming through. So this is kind of a global phenomenon. And I think all of us who celebrated the NHS's 75th anniversary last week kind of had this sense of a combined sense of promise and trepidation, trepidation with what's coming, but also the sense that if us leaders of these kinds of organizations can't find a way through that create a renaissance in our health and care system, then really, what is the point of all of these kind of webinars and chit chat? So what we're going to focus on today is how we've really kind of soul searched a little bit at NICE to say massive health system and economic pressures, massive industry pressures. What's the role that NICE can play in finding our way through this? And I think where we always land up is it's hard to believe that value-based healthcare is not going to be part of the solution of the future. And in that value-based healthcare, what's the role that NICE plays? So I'm going to talk a little bit about what stays the same, a little bit about what's going to change, some early signs of success, and then what happens next and how we'd like to have you involved. So on the what stays the same, the great thing about NICE is that our core purpose will remain the same for forever, which is, as it says on this slide, we help practitioners and commissioners get the best care to people fast and ensure value for the taxpayer. That rolls off the tongue, but it's not that easy to do because there are these two big kind of constituents that we serve. There's the patient, the person who's sitting in the consultation room wanting the best treatment right now. And then there's the taxpayer who may not be sick right now, but wants to know that when something does happen, that they have got the most care available for every pound of taxes that they pay. And it's that tension between, what's clinically effective and what's cost effective that we constantly manage. And so does that mean that we continue to get, with increasing frequency, I'd say, pressure from almost every part of the ecosystem, from politicians, from clinical groups, from patient groups, from health and care system leaders. Absolutely, we do. But that's our role, is to manage that pressure, to stay true to our core purpose, and to keep the historic strengths that we've had that enable us to manage that tension. So the things that are not going to change are, one, our core purpose, and two, our historic strengths, which we think are independence, rigor, and transparency. So those can't change, because otherwise we can't manage the tension. So that's what's going to stay the same. But what's going to change? Well, we know that things have got to change for us to play our full role in the future. And we spent a lot of time over the last year speaking to many people who will be on this call today and others. So patient organizations, clinician groups, health and care leaders, people in government, to say, what do you need from NICE in the future? Paint us the picture of 5 years' time. What do you want? And this is what we said. And we got, no matter who we spoke to, actually, we got a pretty remarkably similar set of recommendations. You basically described 2 core goals that we need to deliver. The absolute minimum that we need to deliver is on the left-hand side, which is you want kind of timely, integrated guidance on one topic that gives you a one-stop shop. So you want to not look all over the NICE website for something in a particular clinical area. You want to go to one place, and you want to know that it's up to date. So you were saying to us, living guidelines don't need to be updated every single week, but we do want to know within 6 to 12 months of practice changing evidence coming on board that NICE has updated their guidelines. That's the minimum on the left-hand side. But the more ambitious of you actually also painted a picture for us of the maximum, which was, hang on a sec, we live in this incredible single-payer system with amazing real-world data. Isn't there more than we can do at NICE than just transmit, right? Transmit, this is what's clinically effective, this is what's cost effective. We would love NICE to be more part of the learning healthcare system, so that whilst we do transmit what is clinically and cost effective, we also gather qualitative and quantitative data on, are you using our advice? If not, why not? How can we update our advice based on your feedback? So much more a kind of iterative learning loop with our partners, which will be many of you, everybody from industry to commissioners to providers to voluntary community sector organizations. So that's the 2 things that you said must have, integrated guidelines up to date that incorporate everything, diagnostics, devices, digital medicines, and be part of the learning system. Don't sit away on the side. So that's where we're going. How are we going to achieve that? Well, you really said that please don't give up the things that we rely on from you when you're making these tough decisions. So please don't give up the independence, rigor, transparency. Those have got to stay. But please do add relevance, timeliness, usability, and demonstrable impact. So you'll now see everything that we do at NICE, our business plans, our board meetings, our performance reports are all orientated around those 4 additional strengths that we need to develop. And I'm going to spend a little bit of time talking through what we think that they mean in practice. So in practice, we think more relevance means that we need to work with you to focus on what matters most. More timely and usable means we need to give you more useful advice, and more demonstrable impact means that we need to constantly learn from data and implementation. Okay, a little bit more detail on all of this. So on more relevant, there's lots of text on this slide, but the 2 things that I'd love you to take away from it are, one is we've got to give advice on topics that you think that the broader health and care system, so that means social care providers, managers, commissioners, clinicians, voluntary community sector organizations. What are the things that you think are going to move the needle in this very pressurized time we find ourselves in? So Jennifer picked up on some of those, children and adolescents' mental health, productivity enhancing technologies, things that don't lead to increased pressure on health and care system resources. And so we need to develop a mechanism, and Jonathan's going to talk a little bit about that, about how we get that feedback from you so that the advice we're developing is in the areas that are relevant to you and you can actually action. They're not some, kind of castle on the sand off to the side. So that's the first thing. Give advice on topics that are relevant to you. The second thing is that is to think about how we evaluate those topics. So as we look at new types of technology, we need to look at new types of evidence, so more real-world evidence, more observational studies, etc. But also we need to think about what society values. So historically, all of our methods have focused on length and quality of life, but it's important for us to consider other things that society may value: health inequality, environmental sustainability, severity of disease, etc. So not only will we commit to focusing on things that matter most to the broadest part of the system, but also that our methods will consider the elements of that are important to society as a whole. And we will continually update our methods through modular updates. So that's more relevant. The next one, more timely and usable. So, if we put ourselves in the position of that patient sitting in the waiting room, if what you want from NICE is, if there is an intervention that is demonstrably, more effective and more cost effective, you don't want us to take many years opining on it. You want that advice to be as quickly kind of published as possible. And so there we're looking at more proportionate approaches to our appraisals. So for the things that are a slam dunk, yes, this is clinically effective, yes, it's cost effective, let's look at those as quickly as possible. And then there's some things that will be tricky, right? The clinical effectiveness is not quite certain. There's a bit of a wrangle over the cost effectiveness. Let's take time with those things, but let's do the slam dunk ones slightly, not slightly, quite a bit faster. So there's one, more proportionate advice. Two is, what we're hearing from people in the health and care workforce is that you are run off your feet. You cannot be going through a thicket of a website into a 50-page PDF to try to find what we're saying on X topic. You want advice that is really easy to find, so that all NICE's advice on one topic, for example, diabetes, is in one place. You don't have to look in lots of different places. And ideally, what you've told us is you would like it to be in your consulting room when you are with the patient or the person. So we're working hard on thinking about how we can make our advice measurable and integrate it into electronic health records. So that's the two parts about more timely and usable: proportionate advice, and then arranging it in a way that is easy for you to find and navigate, in language that is easy for you to understand, and ideally integrated into your own kind of electronic systems. So that's the second thing, useful and usable advice. The third is greater demonstrable impact. And here there are a couple of bits to pull out. So firstly, when we were first created, we didn't have the benefit of fantastic implementation networks like Get It Right First Time or the AHSNs. So rather than NICE having a cottage industry of implementers trotting around the country, we really need to strengthen our partnerships with these big implementation networks. Voluntary community sector fall into that category as well. So there's much more partnership for implementation. Then the second thing is we need to learn about what your experience of NICE guidance is. So the most common thing that happens to me when I trot about is people say, oh, your bipolar guideline, I really didn't like this bit. And oh, that guideline, I really didn't like that bit. And I say, oh, have you told the team? And people say, well, we don't quite know who to tell. So that we will create kind of this hopper whereby we can get stakeholder engagement and feed it into our guidance production so that you're not kind of wandering around the impenetrable NICE thinking, who do I actually give this feedback to? So there's much more active seeking of system intelligence, as well as much more partnership for implementation. And then the last point here is much, much more use of real-world evidence. So we launched our real-world evidence framework last year, and our committees are getting increasingly confident in the use of it. So those are the three big kind of building blocks of how NICE will look different in future. Now, rather than creating the plan, which we did kind of last summer, and coming straight to you and saying, this is what we're going to do, we thought, actually, let's get a few projects under our belt to demonstrate that we are an organisation that is up for doing this. And so that when we come to you with our plan, there's a little bit of a track record of this is what we've delivered already. So in terms of these three areas, this slide gives you some sense of what happened at NICE last year. So on focusing on what matters most, we heard from you, you need to say more on digital technologies. And so last year we appraised 20 digital technologies. To Jennifer's point, one of the first areas we focused on was digital technology in children and adolescents' mental health. So that's the first thing. Secondly, we heard from you, you need to summarize what NICE advice says on big, important topics like health inequalities. We cannot be reading all 25,000 pieces of recommendation to try to figure out what you're saying. So we launched, together with Bola's team at NHS England, and aligned to Core 20+5, web resource for health inequalities that commissioners can go to and say, this is the curated list of all of NICE's recommendations on health inequalities. If you want to know where to start, these are the good places to start. And then we also looked at a big area of need, which was antimicrobial resistance, and created a new mechanism with NHS England, whereby we brought the first new antimicrobials to the market in this country for a decade. So for people with antimicrobial resistance, which can often be fatal, there are now new antibiotics available. So that's what we did on Focus on What Matters Most. On useful and usable advice, the number one thing we get is, please, can you be faster? So we are happy to report that across our whole medicines portfolio, last year we were 17% faster than the year before. And we've got plans to get faster still this year. And we did that through what we call these proportionate approaches to technologies. When we've got simple medicines that are quite easy to appraise, we do them much faster. And the proportionate approaches were applied to medicines that could affect about 175,000 patients over the next couple of years. So that's the first thing. Then the other thing we did on real world evidence is, as I said, we launched the real world evidence framework. It's been viewed lots of times, 20,000 times, and our committees have started to use it. So we got our first medicine through that used the real world evidence framework in its evidence submission. It's called mobocertinib, and it's for a rare kind of, a relatively niche kind of area of lung cancer. And through all of this, you've continued to use our advice, for which we're very grateful. 11.5 million looked at our guidance last year. So, that continues to go from strength to strength. It grows kind of 10 to 15% every year. So we're making good progress. I think we've got enough track record to say, actually, what Jonathan and I are talking about today is not a pipe dream. It's something that we can achieve. So what can you expect from us this year? We're going to build on what we did last year. So the first thing is we've got a single team who's going to decide what topics we focus on, having had a good conversation with the broader system on what's relevant. And Jonathan's going to explain a little bit about what that looks like. Second, we understand with industry that we can be a little bit impenetrable because we've got so many front doors. So we're coordinating all of our early engagement teams into a single front door. So there's only one place that you need to go, whether you're a digital technology or a big pharmaceutical company. There's just one place you need to go to figure out how to navigate NICE. The third is we're further committing to increasing our speed across both medicines and medtech. We're going to increase the speed of our appraisals by 15% by, again, taking out these unvalue added steps, never by compromising our rigor, transparency or independence. Then fourthly, we're going to continue to expand our medtech program because we completely see that devices, diagnostics and digital are going to be so important to the future of health and care. And so last year we looked at some early stage devices, diagnostics and digital. And this year, actually, we're going to look at much later stage technologies that have been in the market for ages, but have never really had a value-based price set. And so we're going to look at some of those, which will give commissioners much more confidence to, if there is a premium demanded by certain technologies, to know what they're paying for. Next, we're going to focus much more on integrating our advice on medicines and medtech into our guidelines. That's one of the most common things we hear is, oh, it drives me mad when NICE guidance says different things at different stages, because we want the guideline to be the one-stop shop. We're not going to have completely solved that problem next year, but we're going to be doing more and more of that. And then lastly, we're going to track the uptake of our guidance in key areas to understand why it's not being followed, what more we can do, and how we can work with ICBs and other kind of commissioners to address some of those issues. So another action-packed year ahead for NICE. But really, I just wanted to end by saying, we are a small part of the great health and care village and life science industry that we find ourselves in. And so we really want to build all of this with you. There will be some immediate opportunities, for example, through our prioritization framework that Jonathan's going to talk about, or our recruitment of topic faculties, which Jonathan's also going to talk about, for you to get involved. And then there's all the usual ways that you can stay abreast of NICE work or contribute through being part of a committee or an expert group or a reference panel or something like that. So thank you for joining. Looking forward to the Q&A and looking forward to working on all of this together. Jonathan, I'm going to hand over to you now.
Thank you, Sam. And good afternoon, everybody. My name's Jonathan Venger. I'm the Chief Medical Officer and Interim Director of the Centre for Guidelines at NICE, having joined the organisation in January from NHS Digital and NHS England. I'm an emergency and pre-hospital physician in the southwest of England. The first question is, why do we need to prioritise? And I think it's self-evident from the introduction we've had from Jennifer and Sam that there is an increasing portfolio of activity, innovation, research and development that needs to be mastered by NICE. And at the same time, of course, we have a growing portfolio of guidance. And so the challenge that we face is that we have already over 300 guidelines. We have a wide portfolio of guidance available. And obviously, if we continue to keep that up to date whilst delivering new guidance, then eventually we're just going to run out of capacity. And so a really important challenge for NICE as we implement our new strategic direction is to be clear about how we are going to prioritise our work and to be more transparent and more open and more consultative with our key stakeholders in order to ensure that we maximise the relevance of the work that we do in order to really meet the needs of the health and care system, commissioners and the patients that we serve. And so prioritisation is a role that falls to the CMO of NICE, and it's a role that I'm embracing and relishing the opportunity to review how we prioritise and make sure we do that in a consistent and transparent way. So the way that we're going to approach this is really to focus on what matters most and what the system really needs. And as a practicing clinician in the NHS, and I work in the emergency department in Bristol every week, it's very apparent the challenges that we face as a health and care system. And some of those challenges are unprecedented and really are putting pressure on our staff across the health and care system and are obviously really important areas of concern for patients and public, for healthcare providers and for those who organise and run the system. And so a really important part of my role and the role of NICE is to really focus on those things that matter most and to be clear about how we are going to do that and how we will prioritise in the future in order to manage that increasing evidence base, that increasing innovation, new drugs and technologies coming to market, and big new challenges in things like genomics and artificial intelligence, which will further challenge us to ensure that we are utilising cutting-edge technologies in order to provide the very best health and care that we can. So to open up, the key thing is to be clear about the prioritisation framework that we're going to use, and to have a clear and transparent framework across all of NICE's guidance products, which we can apply consistently, which we can publish, having consulted on it extensively, and I'll come back to that consultation very shortly. And we need to make sure that we prioritise the things that are most relevant and which will be most impactful for the system. And therefore that NICE is seen as being part of the solution to the current challenges that we have in health and care, and never as part of a problem, but part of a solution to those challenges that we face right now in 2023. And so we're working to develop that prioritisation framework, and that framework is already starting to enter a consultation phase. We're drawing on the best of international examples, and we will be seeking wide input to make sure we get this as good as it can be. Of course, it's never going to satisfy everybody, and some hard decisions will need to be made. But my view, and the view of Sam and my colleagues within the executive team of NICE, is that it's by being open and transparent about those decisions and how we make them and how we reach them, that we have the best opportunity to ensure that we make good decisions and that we take you with us. And so that framework will itself inform the work of a new prioritisation board that will work across the entirety of NICE. It will be a single board that will unify the entire approach to how we prioritise our work, and also help to ensure that our outputs are coordinated in the way that Sam has described, so that we can start to bring together the various guidance products into single integrated guidance that is really useful for the system. And so that prioritisation board will come into being in shadow form in the autumn and will be fully up and running by the end of this financial year, and will be the key and pivotal area in which guidance decisions are made and prioritisation is undertaken. And we're committed to ensuring that we're as transparent as possible about that and how we are reaching those decisions, so that our stakeholders, so that you can see what we're doing, how we're doing it, and why we're doing it. That in turn will be informed by a unified approach to horizon scanning across the organisation. Again, we're bringing together a range of functions to work more closely so that system intelligence is collated in a single place and is brought directly into that prioritisation board, along with input from stakeholders, patients and public partners, and so that board has a wide consideration of important factors in reaching decisions as to what NICE should focus on. And to ensure further transparency, we will publish an annual forward view, which will describe the prioritisation decisions that we've made in the previous year, that will look forward into the coming year, and that will also look further ahead, pointing forward to where NICE is going to focus and our anticipated areas of further development and innovation, so that we have better communication with the health and care system, and better communication with our stakeholders. Now, I've said quite a bit about how we're going to make sure that we seek views, and we are very serious about effective consultation. So in the autumn, we'll be launching an external consultation process, and we'll be seeking feedback on our prioritisation criteria, on our prioritisation approach, and our plans for the new prioritisation board. We're pleased to be working with our NICE Listens programme, which will allow us to undertake deliberative and structured engagement with the wider community, and that will also be commencing in the autumn, so that we can really get proper representative feedback from a very wide range of stakeholders to inform our work. And underpinning this will be a consistent approach to strategic engagement, so that we are consistently aligned to what's going on in the system, listening hard to what is actually relevant to health and care providers, commissioners, patients and public today, and therefore ensuring that our guidance is as impactful as it possibly can be. And we are committed to ensuring that there's lay representation in the prioritisation board, and a strong lay and patient and public voice that informs the work that we do throughout. And so you can expect to hear more from us around our prioritisation, and also see more about what we're doing and how we're doing it, in order to ensure that we use our resources to the best available way that we can, and to get the most out, so that our guidance is really relevant to today's challenges and meets the needs of users. At the same time, it's really important that we focus on making our guidance as useful and usable as it possibly can be. As I alluded to earlier, we've got more than 300 guidelines on the portfolio already. And so one of the key challenges for the prioritisation board won't be just about selecting new work. It will also be about choosing where we update and also choosing where we choose to retire guidance because it's less relevant or has been superseded by other work. And that's going to be a difficult decision, but it's a decision that we have to make and that we have to do transparently. However, in order to ensure maximum relevance and usable advice, we are starting to group our work in the guidelines portfolio into what we're describing as suites. And so we have 4 key topic suites where we are bringing together areas of guidance in order to focus on activity that will ensure that our outputs are swift and responsive and are as usable by our community as possible. So those 4 topic suites are mental health, cardiometabolic disease, which includes cardiovascular disease, diabetes and weight management, cancers, and women's and reproductive health. And what those suites do is they bring together areas where we're already working, but will create, in effect, an expert faculty, which will be a standing faculty of clinicians and advisors who will work in those specific areas with good familiarity and strong expertise in those topic areas, and who will work to ensure that the guidance that we produce in those areas is up to date and relevant. And so where updates are required, we will move swiftly to ensure that they are enacted. And as Sam has said, within 6 to 12 months of practice changing evidence in these topic suite areas, our topic suite faculties will work with our development and technical teams to update our guidance so that our users know that that guidance is relevant and up to date. But of course, there's a lot more than just those 4 topic suite areas. And so there's a 5th general suite where we will work to produce, update, and review other guidelines that don't fall readily into one of those 4 areas, but which are still important and prioritised by our prioritisation board. We believe that this approach will ensure that our advice is much more timely and much more useful and usable to users and really responds again to what people need. As Sam has alluded to, it's sometimes the case that evidence is clear and guidance can be updated very quickly on the basis of emerging research. On other occasions, we need to take more time and we need to adjust our approach according to the actual requirement and the evidence itself, so a proportionate approach. And so we developed a multi-criteria decision framework which helps us to understand where to update, what the right proportionate approach to update is, what the right methodologies are in order to achieve something that gets the right information into the hands of health and care professionals swiftly, but does so in a timely and efficient way. Historically, NICE has tended to use the same kinds of methodologies for different requirements. And what's important is that we adapt some of our methods to be proportionate to the requirements of a particular update or guideline. And progressing our work is well underway. These suites are starting to come together. They're in various stages of development. But across the Centre for Guidelines, we are now reorganising in order to deliver against this new model, which we believe will ensure a more proportionate, useful and usable approach that is more timely, not truly living in terms of updated every week, as Sam has already said, but updated in a timely way, in a proportionate way, in a way that makes information available to health and care practitioners where they need it and when they need it. So that's a quick summary of where we are in terms of prioritisation and producing useful and usable advice in the Centre for Guidelines. I'm aware that we've talked at you for a bit, so I thought it would be time to have some audience participation. And in the spirit of consultation and getting feedback, you'll find there are 5 areas of a potential impact when NICE might focus. On your screen, I think there is a polling button which allows you to poll against these options, and we invite you to click your top 2 of where you think NICE can have the biggest impact, considering the specific role that NICE has within the system. So you can have addressing current challenges in the health and care system, reducing health inequalities, providing independent cost-effective analysis of new treatments, supporting resource management that's linked to guidance implementation in the health and care system, or promoting sustainability in the NHS. And I invite you to give us your votes now on your top two, because every opportunity for me consulting with stakeholders is an opportunity to get some feedback. So I'll give you 5 or 10 seconds to consider your best response to that. And here are the answers. So top of the list is providing a cost-effective analysis of new treatments. People are still voting, so there's a chance to, if your horse is lagging behind, you can bet harder. Okay, so providing a cost-effective analysis of new treatments is, of course, NICE's kind of original mission. And I think it's important that we do remember and retain that. And as Sam has said, we are committed to maintaining our independence, transparency and rigour. But I agree with those of you who've said about the challenges in the health and care system as being a really important area that we need to focus on now. And it's good to see the others represented too. Our prioritisation framework, which is currently in draft form, specifically calls out inequalities and sustainability in the NHS. And we're also aware that it's really important that we understand the impact of our guidance as it's implemented in the system. And it's really important that we take due account of what the system is able to implement when we are developing and publishing guidance for the health and care system. So thank you very much for your feedback and thank you for listening. I'm going to hand back to Jennifer now, who is going to chair the Q&A session.
And Sam, both your presentations, there's lots of fantastic questions, so thank you very much for those who've asked them, and please keep them coming, and I'll try and get to as many as possible. So let's just turn to the first batch. I think there's quite a lot of people who are asking questions about the prioritisation framework and how NICE interacts with other agencies, particularly national agencies. And the ones mentioned are MHRA. How does NICE's plans sort of dock with MHRA plans? Where in the process is NHS England included? Because the interactions between NICE and NHS England, the questionnaire claims are not currently transparent. And there's also another one about how does all this link to the Advanced Access Collaborative, the AAC. So I don't know who wants to take that on. Maybe Sam, you first.
Have a go. Yeah, exactly. So there were lots of nice detailed questions, and I think they were how we link to different partners in different ways. So the MHRA, there were two questions here. One was how we thinking about the recent announcements regarding MHRA's increasing use of reliance with other international regulators. And then the second was what's happening with ILAP. So on the first of those, we noted with interest the results of the regulatory review, where the MHRA said that they would develop increased reliance mechanisms with regulators such as the FDA, Canada, Singapore, Australia. We think that means three things for us. It means that there is a possibility that those technologies, which are many of which are medicines, I think we're talking about, will come to the UK quicker. So we need to do better horizon scanning with some of our international partners. And we've already started to talk to agencies like us in those geographies to figure out how to do that. And then the second thing and more fundamental thing is that we think that will mean we need to work hard with companies on what kind of endpoints we consider appropriate for a NICE appraisal. Because as we all know, different regulators don't necessarily require clinically meaningful endpoints in order to say yes. So increased regulatory reliance, yes, there is a knock-on effect on NICE, and we need to address it by getting on top of the horizon scanning, working with our international colleagues and working with industry on what kind of endpoints we can accept. And obviously working very closely with MHRA, but that goes without saying. Then on ILAP, yep, ILAP is still going. We have approved more than a couple of ILAP medicines. And I don't have the stats for you today, but the ILAP medicines are always quicker than I shouldn't say, on average, both last year and this year, ILAP medicines are substantially quicker at getting through a NICE appraisal than other medicines because of all the work that we did upfront with them. But I don't have the stats. I can add them into the Q&A. Then in terms of the AAC, yes, they're a very valued kind of convening body. And basically what the AAC does, the Accelerated Access Collaborative, it brings together all of us, so NHS England, NICE, MHRA, etc., to figure out how we all are playing together. So nothing that we've said today, I think, doesn't mean that we'll work closely with the AAC. And the last one, sorry, I'm going to be quick. NHS England, there was a specific question there about, are we going to change our relationship with commercial medicines? No, I'm sorry, questioner, we are not. What we were talking about in terms of a single front door is when you're new to NICE or before you start an appraisal and you're thinking about scientific advice, we're just going to have one place where you need to come, whether you're a diagnostics device, digital or medicine. So that you don't have to figure out, oh, do I go to the AI service, or do I go to Office of Market Access, or do I go to scientific advice? There'll just be one place, and we'll help route you to the correct destination.
Fantastic, thank you. There's another question which is about inequalities, and somebody is asking, when do we start to see quantifiable evidence of health inequalities considered within the technology appraisal guidance? And often there's a note saying in NICE guidance, health inequalities are factored in, but almost never the detail is provided. So can you just say a little bit more about health inequalities there? Thank you.
Yeah,
is that
Jonathan,
Sam?
Yeah.
Yes, I'll turn to Jonathan in a sec, yeah.
Great. So in terms of technology appraisals, you're exactly right. We don't have a mechanism at the moment for including them in the calculation. As you know, with our technology appraisal methods, we're going to be doing modular updates, and this is on the list of topics we'd love to look at. So I can't give you the exact date of when we're going to look at it. In our guidelines program, we are in fact piloting a tool from the University of York, which can aid a more structured conversation in the committee on some elements of health inequality. And so we're working that through at the moment. And if initial feedback from the committee is very positive, and it does help us to kind of quantify effects and kind of include it in our deliberations a bit more. And if that is, at the end of the pilot, it's concluded to be successful, we'll roll it out through our guidelines program.
Fantastic, thank you.
Yeah, can I just add to that, actually? Yeah, I mean, Sam is correct. I mean, the pilot is going very well in that regard, and we recognise the real challenges that this represents, not least because the evidence on which we base our guidance can often itself be significantly impacted by challenges in relation to health inequalities, and the way that evidence particularly reflects deprived populations. So we're keen to address that, and we're looking at a variety of ways of approaching that. It'll be, say, an explicit criterion in prioritisation, but also in our guidance production. And the piloting work that we're doing at the moment is actually very positive, and we're very committed to continuing that along those lines to do whatever is possible to take due account of that in the work that we do and the guidance that we produce.
Thank you so much. There's a clutch of questions about social care, about is your single front door aspirations, the one-stop shop, include responses to social care, and how do we make sure that social care is properly represented in the panels, not just for the medicines, but also for social care treatments itself and care pathways? So is that one for Jonathan?
Yep.
Yeah, so the single front door that we've described is kind of an industry engagement process, so less in relation to social care, but social care is a explicit part of NICE's consideration in relation to our wider prioritisation, and in particular, we are focused particularly on the interface between health and social care. There is a really important area there, where NICE has, I think, historically produce very useful and valuable guidance at that interface between health and care. We are committed to continuing to work within the social care sector. And in fact, actually, we now have an advert out this week for a social care advisor who'll be working closely with my team in the clinical directorate in order to continue to support the social care elements of the work that we do. And furthermore, the prioritisation process that we're introducing will specifically address elements in relation to social care. So I think it's a really important part of what we do, and we need to continue to develop our guidance, taking due account of that very close relationship between health and care.
Yeah, that's very good to hear, given demographic change. Thank you. So there's a question here. Obviously, NICE considers the costs and benefits, but there's a question, will NICE consider the impact related to service capacity of some of its decisions in its decision making, given the scarcity of workforce and other things?
Should I start, Jonathan?
I think that's you. Yeah.
Because you're poised. Exactly. Yes. So we'll do that in two ways. One is by prioritising what we look at. So at the moment, in terms of our guidelines, devices, diagnostics, and digital technologies, we're thinking about where are the biggest pressures in the NHS and where are the biggest use of resources, and can we prioritise our guidance in those areas to look at wiser use of health and care resources. So an example of that, as I said, is digital technologies for cognitive behavioural therapy, because we know that the waiting lists are incredibly long, or digital technologies in reading of chest x-rays or chest CTs, because we know there's a shortage of radiologists, so that kind of thing. So we can prioritise to look at topics that we think are likely to have a big impact on health and care resources, and that's what we're actively doing. But then I think the second thing is that when we publish our guidance, we also alongside it publish a resource impact assessment to say, okay, we gave this guidance, and this is what we think it means in terms of GP visits, and this is what we think it means in terms of hospital visits. And in speaking to people who kind of manage the purse in different NHS and care localities, they've said to us, we need a little bit more from you on that. So this year we're working with those stakeholders to say, what's the more that you need? And they say things like, if it's a chemotherapy medicine, we need to know how long it takes to infuse it, because actually that really affects our costs. And so we're continually refining that information that we give based on what the people who actually implement this are telling us they need to know.
Very good, thank you. There's quite a few questions about compliance and tracking uptake of NICE's guidance. So people are really interested about how you can do this, and someone is asking about trust level data, or indeed practice level data. So can you say a little bit more about that, and what will be the impact if NICE's guidance is not followed, is the subsequent question.
Jonathan, I know I should stop talking, but you want me to do this?
Go. You start, Sam, and I'll add. I think that's probably the best thing.
Yeah.
Okay, great. So I think historically what we've done is we've looked at impact reports. So we've gone area by area to see how NICE's guidance is followed, but then that means you only get a very patchy picture. And in the last 5 or so years, we've actually got much better national data sets. So what the team is doing this year is looking at big areas like Core 20+5, planning guidance, etc., and saying what are the big topics there, where are our guideline recommendations that relate to that, and therefore where are the national data sets that we can get data on whether people are complying with it, and at what level, is it practice level, trust level, etc. So we're doing that almost as a thought experiment for ourselves. We don't really know how well it's going to work. And then we're going to be coming to different people in the system to say, okay, this is the kind of data we can collect. How would you like us to use it? We don't really ever see ourselves as the enforcer, right? That's not our role. We're the informer, not the enforcer.
Yes.
But the question will be, how does NHS England want to reflect on this in their planning guidance? Can it be helpful for trust compliance leads to illustrate their compliance with quality standards and therefore reduce the amount of work and data processing they have to do? So we're really going to come to the different audiences and say, how can this be helpful?
Fantastic. Jonathan?
Just add to that. So the other thing that we're looking at this year is around how we can digitise some of our quality standards, so that effectively we can collect data from routinely collected data in the NHS to understand the extent to which quality standards are being implemented across the system. So one of the key areas for NICE is to start to produce recommendations and outputs, and quality standards is a good place to start, that are machine readable. And by doing that, that gives us the opportunity to almost automate a system that would allow us to understand the extent to which those quality standards are being met and followed and taken up by the system. And that, if successful, I think is a model for how we could continue to do that. Because what we don't want to do is add burden to the system by adding data, or data collections. What we want to try and do is align our outputs with the existing data collections, so that we can understand and actually measure at various system levels the impact that NICE guidance is having. And I think that would be a very significant step forward for us and for the system as a whole.
Thank you. So there's quite a few questions about the patient and patient involvement, and I think you've spoken a little bit about in the prioritisation process how you might do that. But how do NICE guidance become more friendly and accessible, directly accessible and visible to patients is one question. And the related one, I think, is will there be an a NICE app to help in this regard, and indeed with staff, if you're trying to ease the burden on staff? Thank you. So Sam, I think that's you first.
I can have a go. Okay. So on patient-friendly and patient information, I think that there will be two types of things. One is this year we're creating some patient information resources in really big areas, and those will be available on the NICE website. But in general, we know that there are groups in voluntary and community sector organisations that are much more expert at putting things into patient language and have got much broader networks amongst the patient community than we do. So what we think the solution here is, sometimes we will do our own resources, but we think the solution is much more here partnering with those organisations, such that when NICE brings out a big guideline in an area, that we work with and appropriately fund, of course, the voluntary community sector organisation in that area to be communicating the so what to patients, because they will probably do it much better than we will. And then on the NICE app, yes, that's an excellent suggestion. It's one that we've talked about a lot internally, and I think we need to figure out, where the people who use NICE advice want to see it. Do you want to see it in your EHR? Do you want to see it do patients want to see it as part of the NHS app? Do you really want a separate NICE app? So those are the things we're thinking about, but I can't believe in 5 years' time we'd be sitting here and we still only have a website.
Fantastic. Jonathan, did you want to add or?
No, I mean, I think Sam's captured the key areas. I mean, we are, of course, committed to supporting the very best patient care, but we do that through providing timely and accurate and effective advice to health and care professionals. Some of our products, though, do lend themselves to patient-facing materials, and some of our patient decision-making aids, which we've just updated recently, around things like stopping Z drugs and benzodiazepines. These are very well received by patient groups. We're also very committed, as I've outlined, to ensuring patients have a strong voice in the decision-making process that we have, and so there is an interface with patient groups and patient advocates. NICE's primary function is to ensure that we give excellent advice to health and care professionals and thus benefit patients. But it doesn't preclude us from making sure that our advice is, where relevant, available to patients, accessible to patients, and working with patient groups to promote that.
Thank you. And given time, this is probably the last question, and apologies to those who've asked many other questions. But there is a question here about, clinicians know NICE, they love NICE, or hopefully they do, I'm sure they do. And it's a question that they are very sort of invested in the current methods that they understand, and the methods used to appraise and the rigour and so on. If you're moving to in some cases, more rapid guidance, particularly because of the pace of technologies, how do you maintain confidence in the wider clinician community that this is pucker, this is okay, this is the way to go, beyond the engagement exercises that you will have with the prioritisation process? So maybe Jonathan first and then Sam to finish off, probably.
So, I mean, NICE publishes its methods, and we do that deliberately to enhance confidence in NICE's processes and products. And so we will update our methods and our guidelines, our manuals to reflect changes in process, and we will consult on those, and we will make those transparent and available. There is a challenge, I think, in that we learnt a lot during the pandemic about what we can do at pace and at speed, and people accepted that was the right thing. Clearly, we're not going to go at that pace and speed in the post-pandemic pandemic period. But what we do need to do is we need to keep moving and adapt to changes in evidence understanding and the wider range of data that we have available to us. For me, I think the essence of this is to maintain that dialogue with clinicians, and that's part of the job of the CMO, of course, but also to be as transparent as we can be, to publish what we're doing, and to therefore ensure we take the clinical community with us. The reality is that NICE's reputation and its future status is based on trust, and trust is difficult to win and readily lost. So I think there's a phrase, isn't there, from the Netherlands, that trust comes in on foot and leaves on horseback. And so we just need to really work to ensure that we maintain that trust by continuing to be independent and transparent and rigorous, and using publication and dialogue as a way of reassuring the community that is a value that we continue to hold dear.
Thank you. And I think last word to Sam on that.
Yeah, just to say, in addition to everything that Jonathan said, we also evaluate ourselves when we change things. So the big last method we changed is the severity modifier. And you'll see that in our board papers, every quarter, we look at, okay, what's the effect of that? We forecast that this is what would happen. What is actually happening? And so we look quarter by quarter, and at the end of the year, we honestly and in public say, okay, we were right or wrong about what we thought was happen, and therefore we're going to change. So we'll evaluate ourselves along the way, as well as being transparent when we make changes.
Thank you so much. And I think this webinar is part of that transparency, isn't it? So thank you both very, very much. Thank you to everyone listening and for all the questions. I'm so sorry we couldn't get some of those, but rest assured, NICE colleagues are going to go through them and find some way of responding to them, I am sure, if either directly or most probably in the newsletter or some other route. So thank you for those questions. They haven't gone amiss. I hope you enjoyed today. Very useful too. It's recorded, as I said earlier, so you can watch afterwards on NICE's YouTube channel. Well done, NICE. In the coming week, you can watch that. And a shareable link will be sent to you anyway for those of you who registered for today's event. So please pass it on to colleagues who couldn't make it today. Remember to use the Get Involved tab to sign up for future updates and NICE news. And thanks very much again for coming and for engaging so fully with your questions. And I hope this is the start of a longer conversation that you'll be having with NICE. So many thanks to you all and our speakers, Sam and Jonathan. Thank you.